runs around teaching neonatology. And I would like to make one more announcement because under the Presidential Action Plan, we have various programs for the postgraduates. One is this PG Club. Then we had the particular meeting, a PG Congress, where the PGs were made to present papers as well as cases. And now we have the next part of our action plan where we are organizing a clinical skills workshop. So it will be a one-day program where the senior-most teachers will be teaching us how to examine each system, the CVS, respiratory, GIT, growth and development, locomotor, etc. So that will be a one-day program. It is being scheduled for October. The most probable date is October 10th. It will be a Saturday, and it will be organized by our secretary, Dr. Gobi Mohan at Kollam. So details will follow. I wish all the postgraduates please note the date. So with that, I once again thanks to the whole team for this wonderful program, and thanks once again. Thank you.
Thank you, sir, for those beautiful words. And I think PGs nowadays get a perspective of every teacher, every senior teacher at every college. It is not only from Trivandrum or Thrissur or Calicut. So that is a good, brilliant that this program is happening. So I invite Dr. Jose to say a few words as well.
Thank you, Dr. Arun. Respected IAP Kerala State President, Dr. Riaz, and the coordinator of the program, Dr. Munda sir, convener of the program, Dr. Andagasevan, teacher, Dr. Purushottam sir, Dali madam, and PMC sir, and all the senior members. Today, the faculty, Dr. Princy, Dr. Gokul. I think the PG program now get a more and more attractive things are doing that under the leadership of Dr. Riaz. The OSCE training program is very important for, previously it was only important for the DNB examination. Now the all part and parcel of the PG examination also DNB. And again, and the OSCE part, the one part is mandatory for OSCE session. So I think this neonatology OSCE is very important for both MD and DNB students. I think we are getting opportunity, the students are getting opportunity to interact with the expert in the field of PG teaching as well as the neonatology aspect. And today the Dr. Princy and Dr. Gokul going to enlighten us how to proceed with the neonatal OSCE series. Already we had one OSCE from Trivandrum that was very much appreciated by our members. So I think this program is also very useful for all the members. I wish you all the best program. Over to Dr. Arun for further proceedings. Arun?
So next I invite...
I lost the connection.
No, I'm here. So next I invite Dr. Mohandas sir. Sir has been instrumental in coordinating all this, and I have to ask him to give a few words for our PGs.
Thank you, Arun. And this week we are having a program on neonatology, OSCE, and it is the faculty will be Dr. Princy, who is Assistant Professor in Neonatology, Government Medical College, Kozhikode, and Dr. Gokul, who is the consultant neonatologist in Astromims Kannur. And I think without much delay, we can proceed for the academics. Arun, anyone else to?
No, sir. Thank you, sir. So I was told to keep it very short and sweet. Thank you all for those wonderful words. I invite Dr. Princy. She needs no introduction. Already, sir has mentioned she's been very kind to host and give questions and very enthusiastic in teaching postgraduates. So next, I invite Dr. Princy, who is the assistant professor of neonatology and pediatrics at Government Medical College, Calicut. Princy, are you online?
If any issue, we can start with the Gokul.
Yes, I think Princy has been having some
issues. Princy is there. Princy is here. Okay. You are not audible, Princy. You are not audible. So I think you can also log in through the phone also and keep the other thing muted. Then through the laptop, you can share the presentation, and through the phone you can speak.
Just mention
Not
the name.
audible. Not
Mention the
audible.
name you're logging in through. Shall I start with Gokul then? Is that okay, Gokul?
Gokul, whether
No, Princy has started sharing.
Sir, am I audible?
Yes, you're audible.
Yes, yes.
now
Please,
audible.
please keep the other device, the laptop device, muted. So the volume you should cut off. Otherwise, there will be echoing.
Okay, sir. Okay.
And if you can make it into screen share mode or the
Full
presentation
screen.
mode. Full screen, yeah.
Full screen.
Okay. Sir, is it okay now?
You are having an echo.
Yeah.
She can mute one of the
You have to
design
cut down the volume in laptop.
Okay,
Then
sir,
you
I have
can-
reduced it.
Okay, this
I
is
think now it is better. You try again.
Slideshow.
So is it okay now?
Yeah, the voice is better, audio is better, but you can go to slideshow mode if possible.
Okay.
Yeah, perfect.
Correct.
Okay. Good evening, all. At the outset, I would like to thank IAP Kerala and NNF Kerala, all the senior faculty members, and for giving me this opportunity and platform for this OSCE. And we will do it in a discussion mode. And all the cases are simple and based on what we are practicing in a day-to-day NICU setup. So going on to first question. You are attending a high-risk delivery and the baby is 38-week gestation age with estimated weight of 3 kg in the recent scan, and emergency LSCS was done in view of pathologic CTG. Baby didn't start breathing after delivery. So what is the order of initial steps of resuscitation to be done for this baby after providing warmth? And the second question, what is the saturation target at the end of 5 minutes? What is the first sign of effective ventilation during resuscitation of the baby? And dose of adrenaline bolus required for this baby? And after how many minutes will you stop resuscitation if the heart rate remains 0? Afra is there? Our
Yes, ma'am.
Afra, I would like to, you would like to answer?
Ma'am, since this is a term baby, the order of initial steps after warmth will be drying. After drying, positioning the airway, stimulating, then positioning the airway, and if required, suction.
Very good, very good. So it is the order of resuscitation has been simplified for a better practical approach. That is, in 8th edition NRP, it has changed to DSPS, dry, stimulate, position, and suction if needed. And second question, what is the saturation target at the end of 5 minutes?
The saturation target at the end of 5 minutes will be 80 to 85%, ma'am.
Very good, 80 to 85%. And what is the first sign of effective ventilation during resuscitation of the baby?
First sign of effective ventilation will be improvement in heart rate.
Okay. And dose of adrenaline bolus required for this baby?
It will be 0.2 ml per kg, ma'am.
How much?
0.2 ml per kg if the route is intravenous or intraosseous, and 1 ml per kg if it is through ET.
Okay. What about the strength and any bolus required following that? NS bolus?
There should be 3 ml saline flush.
Okay. 1 in 10,000. Okay. After how many minutes will you stop resuscitation if the heart rate remains 0?
After 20 minutes, ma'am.
Very good. Very good. Thank you, Afra. So the answers are: the initial order of resuscitation has been changed to dry, stimulate, position, and suction whenever needed. And the saturation target is 80 to 85. And the first sign of effective resuscitation is increasing heart rate, and the dose of adrenaline has been changed. It has been simplified to 0.2 ml per kg, followed by 3 ml NS flush. And when will you call off resuscitation? That is after 20 minutes of effective resuscitation. And even if there is no there is absence of heart rate, you can consider cessation of resuscitation. Thank you, Afra. Next, this is identify what is given in the figure and mention any two conditions showing false negative results, and mention any two conditions showing false positive results. Dr. Sushma is there. Sushma? Sushma is there? No? Pradeep? Yeah, somebody has given it as carbon dioxide detector. Okay. Okay. It is end-tidal carbon dioxide detector. So this end-tidal carbon dioxide detector will change the color from purple to yellow. Yellow means yes. That is, if it is in the trachea, it will change the color from purple to yellow. And this is due to a pH sensitive material that is present in the end-tidal carbon dioxide detector. So whenever it detects the carbon dioxide, it will change the color from purple to yellow. And the conditions where we will get false negative, that is, the tube is inside the trachea, but there will be no color change. Examples are in when there is inadequate ventilating pressures, or there is collapsed lungs, bilateral pneumothorax, very low heart rate, low cardiac output, poor perfusion, obstructed endotracheal tube. In this case, even though the tube is inside the trachea, the purple color will be remaining the same. It won't change to yellow color. And we will get false positive. That is, the tube is not inside the trachea, but still the color changes. In these are we obtain this in defective device, that is, change the coloring package before use itself. Also, when it is contaminated with epinephrine, surfactant, atropine, or gastric secretion contamination, it can change color to yellow. So this is the third question. Darshana is there? Darshana?
Yes, madam. Yes, madam.
Darshana, identify the Doppler abnormality in this umbilical artery. And this is a Doppler of umbilical artery. We have an abnormality here. And what is the staging used for the management of abnormal Doppler? And expand, adapt, and write down mention the formula for pulsatility index. What is the abnormality given here?
Madam, this is the absence of end-diastolic flow in umbilical artery.
Very good. Absence of end-diastolic flow. Then?
Okay, the staging which is used is Barcelona staging of IUGR.
Very good.
Which is used for management of the condition.
Okay.
And ADPT is abnormal Doppler enteral prescription trial.
Very good.
And pulsatility index is the systolic flow, systolic pressure minus diastolic pressure divided by mean pressure, mean arterial pressure.
Mean velocity.
Mean velocity.
Very good, Darshana. So, as we mentioned, this is a Doppler abnormality with absent end-diastolic flow. Here you can see no diastolic flow here in the umbilical artery. And the staging protocol is Greco staging or Barcelona protocol. So Doppler has an important role in both the diagnosis as well as for prognostication of IUGR babies. And this is the main surveillance tool used for IUGR babies. And it can be used for the timing and for the timing of delivery. Its usage has been improved the perinatal morbidity and mortality and better outcome. So here you can see 4 stages. Stage 1, you can see any of the criteria should be there. like umbilical artery PI more than 95th percentile, middle cerebral artery PI less than 5th percentile, and CPR less than 5th percentile, effective fetal weight less than 3rd percentile. Here the mode of delivery is labor induction at 37 week. In severe placental insufficiency, you can get umbilical artery absent diastolic flow, and termination is at 34 week by cesarean section. And in stage 3, you can get reversal of end-diastolic flow. Here, the mode of delivery as CS at
flags, blurring of vision.
you will get a reversal of flow and mode of delivery at 26 week by cesarean section. And regarding ADAPT, it is abnormal Doppler enteral prescription trial. In this trial, they have included a gestation age babies less than 35 week with a birth weight of less than 10th percentile and with abnormal Dopplers. And this babies are divided into two groups. One is early feeding group and late feeding group. In early feeding group, they have started with the day 2. They have started with feeds, and late feeding group in day 6. And outcome was the time to achieve full feeds and NEC. And the results was early commencement of feed has there was associated with the early attainment of full feed, and there is no statistically significant increased risk of NEC in early feeding group. So that is ADAPT trial. And this is the pulsatility index, that is peak systolic velocity minus end diastolic velocity divided by mean velocity. High PI means greater pulsatility and higher vascular resistance. So thank you, Darshana. Now we'll move on to the next question. This is a 28-weeker baby delivered by a preterm vaginal delivery. And this baby had a stormy neonatal period, including respiratory distress syndrome, was admitted in NICU. Baby received 2 doses of surfactant and was ventilated for 4 days. Baby was started on milk feeds through OG tube. On neonatal day 14, baby developed abdominal distension. Ashwati is there? Ashwati? Ashwati? Hello. Pradeep? Pradeep is there?
Yes, ma'am.
Pradeep, identify the condition and mention the severity.
Hello. Hello.
Hello.
Hello?
Hello, ma'am.
Ashwati is there, huh? Ashwati? Hello?
Hello, ma'am. I'm answering through listener, ma'am.
Now?
Hello.
Hello?
Yeah, ma'am. Yes, hello.
Ashwati, identify the condition and mention the severity.
Okay, ma'am. This is neonatal necrotizing enterocolitis.
Okay.
Currently, baby is having NEC stage 1. Severity.
Hello?
Hello, ma'am.
Yeah.
NEC. Severity.
Which stage?
Stage 1, ma'am. No other features. Second slide, can you please show, ma'am?
This is the X-ray, no? X-ray, just see.
X-ray. Okay. This is pneumoperitoneum, ma'am. So NEC stage 3.
3B.
3B.
Okay.
Then second.
Second question, mention 2 radiological signs seen in second stage of this condition.
Okay, in second stage, pneumatosis intestinalis and portal venous gas is seen in 2A and 2B respectively.
Okay. And what are the surgical treatment options for this baby?
Since this baby has pneumoperitoneum, baby may need either laparotomy with resection and enterostomy formation. If 2-6 sensitive sector, maybe we'll have to do primary peritoneal drainage.
Okay, very good. And name 4 evidence-based intervention that can be used to prevent this condition.
Okay. For prevention, ma'am, we have to use antenatal steroids for preventing prematurity, since it is the most important risk factor.
Okay.
Then feeding, there should be standardized enteral feeding with standard feeding guidelines, and predominantly human milk feeding. Mother's own milk or PDHM has to be given.
Okay.
And then pharmacological measures are also being under study, like giving probiotics, lactose-ferrin enlargement, etc. And also restricting the use of empirical antibiotics and proton pump inhibitors, etc.
Okay, very good, Ashwati, very good. So it is stage 3B NEC, and what we have seen in the X-ray is pneumoperitoneum, and what we can see in stage 2 is pneumatosis intestinalis and portal venous gas shadows, and the surgical options are laparotomy, resection of the gangrenous bowel, and enterostomy formation or end-to-end anastomosis. And if the baby is extremely low birth weight who are too unstable for laparotomy, we will go with the primary peritoneal drainage. And evidence-based interventions include increase the use of human milk, that is mothers on milk. And the premature infants who are fed exclusively with the expressed mothers on milk are at decreased risk of developing NEC. And also standard feeding protocol. Current evidence supports strict adherence to the standard feeding regimen reduces the risk of NEC. Also, the agents promote intestinal perfusion like antenatal corticosteroids, PDA treatment, delayed cord clamping, and that promoting healthy gut microbiota like probiotics, and avoid use of H2 blockers and reduce the use of perinatal and postnatal antibiotics. Thank you, Ashwati. Next question. Yeah, Sushma is there. Sushma? Sushma is not there. Bestin is there. Hello. Hello, Bestin. Anyone want to take up the question? Identify the CTG. What is the baseline heart rate and what does it indicate? And mention the condition where you can get early deceleration. So this is a CTG, and this CTG showing late deceleration. This is late deceleration, and ideally this CTG can be used for intrapartum fetal surveillance, and it is showing two graphs. One is fetal heart rate and the second one is this is uterine contractions. And there is a ideally there are four components. This normal baseline heart rate, beat to beat variability, acceleration, and deceleration. And usually the heart rate will be 110 to 160 beats per minute, and there will be 5 to 25 beats per minute of variability, and acceleration up to 5 to 15 beats per minute is normal, and there will be no deceleration. Here you can see the baseline heart rate is around 140 per minute, and it indicates late deceleration. Late deceleration because in after uterine contraction only baby's heart rate started dripping, and this is we will get in uteroplasmal insufficiency. And mention the condition where you can get early deceleration. Early deceleration it is benign, and we can get in when the head compresses during active labor. So the fetal heart rate slows down as the placental blood supply is temporarily reduced. So if it is associated with the other signs of fetal distress like bradycardia and reduced variability, it indicates fetal hypoxia. So here you can see at the end of uterine contraction only the fetal heart rate started dipping, and a fall in heart rate of 15 beats per minute below baseline is significant. Now you can move on to the next question. Bestin is there. Hello, Bestin.
Yes, madam.
Yeah, this is a 27-weeker, 880-gram baby admitted with respiratory distress syndrome. Baby had a STOMI neonatal course and got stabilized. Baby underwent ROP screening later. So identify the image and the severity. Identify the image and the severity, and write down the RBSK guideline for ROP screening, or mention the RBSK guidelines. And when will you do the first screening for this baby? And what is type 1 ROP? So what is the image?
The picture of indirect ophthalmoscopy with ROP, retinal prematurity for this child.
What stage? Severity?
Bridging is there, stage 2.
Bridging, and also some vascular.
Bridge formation.
Some vascular, this thing also there, no?
Okay, fibrovascular, that is in stage 3.
Stage 3, yeah, stage 3. Okay. Okay. And what is the RBSK guideline for ROP screening? Government of India.
All
RBSK
preterm
guideline?
babies less than 34 weeks,
Huh.
or if gestation age is not known, less than 2 kg.
Okay.
And other more than 34 to 36 week babies with the risk factors,
Okay.
like any resuscitation, any oxygen supplementation, sepsis, or blood transfusion, etc.
Okay. And when will you do the first screening for this baby?
It is 27-week baby for extreme preterm. Then we can do it in 2 weeks, 2 to 3 weeks.
2 to 3.
Others in 4 weeks.
Okay. And what is type 1 ROP?
Type 1 ROP needs treatment, emergency treatment.
Okay.
So it includes all stages with the plus disease in zone 1.
Okay.
Then stage 3 disease without plus in zone 1.
Okay.
Then stage 3 without plus with the plus disease in zone 2. And all forms of aggressive ROP stage.
Very good, very good, very good, Beston. So it is stage 3 ROP. Here we can see extraretinal fibrovascular proliferation or neovascularization extending into the vitreous. And the posterior aspect of ridge appears irregular as the proliferation becomes more extensive. And RBSK guideline is infants born less than 34-week gestation age, or if the gestation age is not known, birth weight less than 2 kg can also be taken. And those born between 34 to 36 week, any added risk factors like cardiorespiratory support, those with the prolonged oxygen therapy, RDS, BPD, blood transfusion, those babies with the neonatal sepsis, exchange transfusion, IVH, apnea, or poor postnatal weight gain are all the added risk factors. And the first ROP for these babies to be done at 4 weeks. And in this case, if the baby is less than 28 weeker or less than 1.2 kg, the first ROP screening to be done at 2 to 3 weeks of postnatal age in neonates. And type 1 ROP means any ROP requiring treatment in the next 48 hours. That is zone 1, any stage of ROP with plus disease, or stage 3 ROP without plus disease. And in zone 2, stage 2 or 3 ROP with plus disease. And aggressive ROP in any zone is also included in the treatment needing ROP. Thank you, Beston. Next question. This is a 28-weeker newborn. Baby had a stomy course in NICU during the first week of life. The baby was stabilized successfully. And the USG cranium was done at 3 weeks of life, as the anterior fontanel tone was found to be increased, and the rate of increase in head circumference was more than expected. The findings are given below. Pradeep is there? Hello?
Yes,
Pradeep, yes, what does the yellow line denote in the first figure? You can see, the first figure?
Yes, ma'am. The first figure is cranial ultrasound showing the coronal section.
Okay.
And the yellow line denotes the Levin's index.
Okay.
Which is measured from the midline, that is from false cerebrae to the lateral border of the anterior horn of the lateral ventricle.
Okay. Then when do you consider intervention based on the above measurement?
The action line is the Levin's index more than 97th centile plus 4 mm.
Okay. Okay. What are the probable reason for the condition in this case? This is a 3-week, at the USC cranium at 3 week of life has shown this. So what might be the probable reason?
It's a intracranial bleed, IVH stage 3.
It is post-hemorrhagic ventricular dilation.
Ventricular dilatation, yes.
Okay, okay. Right. Can you mention one temporary and one permanent CSF diversion technique for the treatment of this condition?
Temporary measures, we can do like serial lumbar punctures or ventricular tapping devices, reservoir like Omaya reservoir. And permanent CSF diversion techniques like VP shunt, ventriculoperitoneal shunt.
Okay, okay, okay. Very good. So this is a Levin index. You can see in the coronal plane at the level of third ventricle. It is drawn from the falx cerebri to the lateralmost part of lateral ventricle, anterior horn of lateral ventricle, and in Levine index or ventricular index, it indicates the ventricular volume. And in the conventional teaching, when the Levine index is more than 97th centile plus 4 millimeter, it is the action line. But Neo reviews has shown that the action line is if the Levine index is more than 97th centile plus 2 standard deviation plus 4 millimeter, and if the anterior horn width is more than 10 millimeter, they will do the diversion techniques. But the conventional teaching is that if the Levine index is more than 97th centile plus 4 millimeter, you have to do the diversion. So the temporary CSF diversion techniques are ciliary lumbar puncture, ventricular assist device like Ommaya, and the external ventricular drain, ventriculo-subgaleal shunt. And permanent CSF diversion techniques are VP shunt, endoscopic third ventriculostomy with or without choroid plexus cauterization. Okay, thank you, Pradeep.
Princy, one doubt. In this case, serial lumbar puncture, provided the hemorrhage is not in the aqueduct or anything. Aqueduct okay, lumbar puncture, will it help?
Sir, that time we can directly from AF tapping can be done, sir.
Okay.
Okay, sir. Thank you, sir. And next question. This is a full-term newborn baby weighing 3 kg birth and born by vacuum-assisted vaginal delivery, presented with irritability on day 1 of life, with no history of seizures or feeding difficulty. On assessment, the baby had increasing pallor, tachycardia, and features of shock. And on examination, there was a soft, fluctuant, tender, large swelling over the occipital area, extending to temporal and parietal area on both sides of the scalp. So, Ashita is there? Ashita?
Yes, ma'am.
Ashita, can you answer?
Subgaleal bleed.
Yeah, subgaleal bleed. How do you know that it is subgaleal bleed?
Actually, it is extending on both sides and it's a fluctuant swelling.
Okay.
With the features of shock, which could be collected in a larger area.
Very good. Okay.
In cephal hematoma, it will be confined to an area with a tense swelling, not crossing suture line, and there will be some associated skull fractures, underlying skull fractures.
Very good.
And it will be painful.
Okay. This also will be painful. SGH, subgaleal bleed.
Okay.
Okay. What are the expected complications of the newborn?
Child can go into shock. And neonatal jaundice.
Okay.
And some coagulopathy can also develop.
Very good. Okay. And what is the management?
First of all, if the child is in shock, we should give blood, as there is a chance for collection of more amount of blood, 40 to 60 ml with even 1 centimeter rise in head circumference.
Even 250 ml can be collected.
Okay, ma'am.
Okay. Okay. Thank you, Ashita. Thank you. And it is subgaleal hemorrhage because there is clue of it was an assisted vacuum delivery, and on examination baby had an increasing pallor, tachycardia, and features of shock. There is features of hypovolemia and also a soft fluctuant large swelling that is crossing the midline also mentioned. So other things, cephalohematoma, it is restricted by the suture lines as it is subperiosteal in location. And the expected complications of subgaleal hemorrhage are severe anemia needing blood transfusion, severe jaundice, consumptive coagulopathy, shock with massive hemorrhage. Management is mainly supportive care, and monitoring can be done with monitoring head circumference, vitals, and management of expected complications. So next we have a growing preterm 29-weeker with a birth weight of 1.010 gram in our NICU. And the baby was on minimal enteral nutrition initially and later attained full feeds. The baby has also received pasteurized donor human milk. So Malavika is there? Malavika? Malavika, hello?
Yes, madam.
Malavika, can you answer the question? Up to how much volume of feed is considered as trophic feed?
12 to 24 ml per kg.
Okay, okay. And can you mention any two types of fortification?
Standardized fortification and individualized fortification.
Okay. You want to modify further individualized fortification?
Second, classified into adjustable fortification and
targeted fortification.
Targeted fortification.
Okay. What is the pasteurization temperature and the time for Holder's pasteurization technique? Okay, fine. For
no, I don't know. I don't know that.
Okay, okay. Following pasteurization, which enzyme activity is lost 100%? Hello?
Hello, madam.
Okay, no issues, Malavika. So, as Malavika said, that minimal enteral nutrition up to 12 to 24 ml per kg per day is considered as minimal enteral nutrition or trophic feeds. And we have two fortification techniques. One is standard fortification and individualized fortification. Individualized fortification is further classified into two, that is adjustable and targeted fortification. And in standard fortification, the fortification of human milk with the fortifier according to a standard protocol. Here we don't need any milk analyzer, and we are not taking into account the variability of human milk nutrient content. And it is very simple and it is most commonly used. But the protein intake is not individualized and sometimes it might be very low. Whereas in individualized fortification, it is two types. One is targeted and second one is adjustable fortification. In targeted fortification, what we do is it requires milk analyzer, and it requires labor. It requires labor and cost, and it will take account in, the actual protein content of the human milk. And the fortification of human milk is done according to the analyzed protein content of the human milk. Whereas in adjusted fortification, it will take account the infant's individual protein needs, and it is assessed by analysis of the blood urea nitrogen, which is a marker of protein metabolism. And this also results in improved protein intake. So the pasteurization, Holder's pasteurization technique, we use low temperature, long time pasteurization, that is 62.5 degree for 30 minutes. And 100% lost is bile salt stimulated lipase activities, 100% lost in following pasteurization. Next, you are called to labor room due to possible shoulder dystocia, and the baby is vigorous and crying at the perineum. And she is brought to the VAMA soon after delivery, and you have palpated her clavicle and found that they are intact. However, she has decreased movement of her right hand. This is a video. Nishana is there. Nishana? 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 Jaykrishnan is there. Jaykrishnan? Okay. So here we can see the baby has decreased movement of her right arm. So the question is, which all nerve roots supply to form brachial plexus, and how to differentiate Erb's palsy from complete brachial plexus injury, and what are the associated other complications to be looked for in this child, and recovery of elbow function by what age is considered as good prognosis. Yes, I think George Verghese has given the answer. It is which all nerve roots supply to form. It is C5 to T1 nerve roots supply to form the brachial plexus. So how to differentiate Erb's palsy from complete brachial plexus injury? So George, it is finger flexion. Actually, grasp is spared in Erb's palsy. And other injuries to be looked up as phrenic nerve injury, that is diaphragmatic palsy, and Horner syndrome also to be looked up. And if there is recovery of the elbow function by 3 months of age, is considered as good prognosis. Hello? Hello, Arun?
Yes, Prince.
Is there time or?
I think you can ask.
We can complete the all topics because postgraduate students can remain more if they want. Complete the thing. If Gokul also will be able to continue after this thing, I think we can finish, Princy.
Because at least I think you can cover 5 more questions each at least. 15
Okay.
each. 15 each.
Okay.
That should be fine. The questions are good and I think helpful for them as well. Yeah.
Okay then. Thank you. Next, we will move on to 11th question. So, Afra is there? Afra?
Yes, ma'am.
Yeah. Afra, this baby has crossed 100 ml per kg of enteral feed and you are planning to start HMF fortification. What is the gestation age and weight cutoff for starting fortification according to WHO? And 1 gram sachet is diluted in how much ml of human milk? And what is the calorie and protein content of 1 gram of HMF? And what is the maximum recommended osmolality of feed as per AAP?
Ma'am, gestation weight of less than 1.5 kg and gestation age less than 32 weeks.
Very good. Okay.
And lactodex 1 gram sachet is diluted in 25 ml milk.
Okay. Good.
The calorie content is 3.3 kilocalorie per sachet and protein content is 0.27 gram protein.
Okay, very good, very good. And what is the maximum recommended osmolality of feed as per AAP?
Ma'am, I'm not sure, ma'am.
Okay, good, Afra. And the question, gestation age and weight cutoff for starting fortification is less than 30 or less than 1.5 kg. And this lactodex is mixed in 1 gram HMF is mixed in 25 ml human milk, and it contains 3.37 kilocalories of energy and 0.27 gram of protein per sachet, and up to, according to AP, up to 450 milliosmol per kg is the maximum recommended osmolality of feed as per AAP. Thank you, Afra. Next, we have this is a 37-week baby with serum bilirubin of 20 milligram per deciliter at 48 hours of life and was admitted in our NICU. And what are the Bestin is there? Bestin?
Yes,
Hello,
madam.
yeah.
Yes, madam.
Bestin, what are the risk factors for neurotoxicity? And mention any 2 methods by which you can improve the efficacy of phototherapy given. And what is M-bind? And what is the tetrad of Kernicterus? So first question, what are the risk factors for neurotoxicity?
Prematurity.
Okay.
Then increases the chance of crossing blood-brain barrier in case of IVH or condition like asphyxia or infections.
Very good. Okay.
Then Coombs test positivity.
Very good. Very good.
Then low albumin level or babies with severe acidosis.
Okay. Okay. Mention any 2 methods by which you can improve the efficacy of phototherapy given.
Increasing the body surface area exposure of the baby to the light, phototherapy light.
Okay.
Maximum exposure.
Okay.
And
okay.
And
what
by adding extra white cloth over the
surface. Okay.
Reflective surface, and the illumination, proper illumination.
Okay. What is M-bind? Okay. What is tetrad of Kernicterus?
Hello, madam?
Tetrad of Kernicterus. Kernicterus tetrad. Okay, no issues. It is so the answers are what are the risk factors for neurotoxicity? So for easy, we have a mnemonic A, B, C, D. A is acidosis and low albumin, hypoalbuminemia. B is blood-brain barrier disruption, like conditions like asphyxia, IC bleed, and sepsis. C, we have Coombs positivity. D, any displacers of bilirubin, like fatty acid from intralipid and ceftriaxones. And E, extreme prematurity or encephalopathy. And how you can increase the efficacy of phototherapy, like use of blue light LED, increase the area of exposure, and increase the intensity by reducing the distance, and increase the number of units, and usage of aluminum foil. And what is M bind? We know M bind and we know bind, but M bind is modified bind score. In modified bind score, we have added altered gaze. That is, it has two scores. Normal means normal gaze, that is 0 score. And if there is sunsetting or paralysis of upward gaze is there, it is given a score of 3. So any bind score less than 3 is there is no indication or diagnosis of acute bilirubin encephalopathy, or if the M bind score is more than 3, it is a positive diagnosis of acute bilirubin encephalopathy. So in bind score, there is MMC, that is mental status, muscle tone, and cry. Along with that, in M bind, we have added altered gaze. In that, it is normal, it is 0 score, and when there is sunsetting, it is 3. So if there is more than 3 or more, it is indicative of acute bilirubin encephalopathy. Then what are the 4 tetrad of Kernicterus? It is dyskinetic CP, auditory neuropathy, and paralysis of upward gaze, and enamel hypoplasia of the deciduous teeth. Now moving on to next question. Jaykrishnan is there?
Yes, ma'am.
Jaykrishnan, this is a male neonate with an imperforate anus. What is demonstrated in the clinical photograph, and what is the likely anorectal anomaly in this neonate, and what other gut anomaly would you like to rule out clinically soon after birth, and how? And this child had recurrent UTI after all surgical procedures have been completed. Write down the 2 possibilities. What is demonstrated in the clinical photograph? What is it?
Madam, rectourethral fistula.
Yeah. So what is this condition? Meconium? It is meconuria, right? Meconuria. Hello? Okay. This is meconuria, and it is associated with the rectourinary fistula, and it is mostly seen in high anorectal malformation. It is seen with anorectal malformation. And what other gut anomaly would you like to rule out? It is tracheoesophageal fistula, esophageal atresia, by inserting an nasogastric tube. And this child had recurrent UTI after all surgical procedures have been completed. Write down the possibilities. That is, it can be due to VUR, obstructive uropathy, or missed or recurrent rectourinary fistula. Okay. Thank you, Jaykrishnan. Next question. This is the imaging study of a male newborn baby with abdominal distension and palpable bladder. Ashwati is there? Ashwati? What is the investigation? And what is the diagnosis? How do you treat the problem? And write down 4 long-term complications.
This is MCU, ma'am.
Yeah.
Picturating systolic ventral.
Very good.
Diagnosis is POV.
Very good.
Posterior urethral valve. And treatment, initially we have to decompress the bladder by inserting a 6 to 8 French feeding tube. Then we have to manage electrolyte imbalance, anything like that.
Okay.
And surgical management can be done after stabilizing the baby by doing primary ablation or vesicostomy if that is not possible.
Okay. For long-term complication?
Long-term complication, baby can have CKD due to recurrent UTI or renal dysplasia as a part of this bladder outlet obstruction. Then
Okay, good, Ashwini, good. So the diagnosis, it is MCU. The investigation is MCU. Here you can see the dilated posterior urethra, and the diagnosis PUV. And how do you treat the problem? It is cystoscopy and valve fulguration. And the complications, the long-term complications are repeated urinary tract infection, persistent VUR, bladder valve syndrome, valve bladder syndrome, and chronic kidney disease. Thank you, Ashwati. And this is the last question. Identify the instrument. And Shruti is there. Shruti, identify the instrument. What is the ideal gestation age for screening of preterm babies? According to JCIH 2019, what is the timing of screening, identification, and intervention with regard to the machine? And write down 4 indications for screening. Shruti is there? No. Then this is Beraphone. This is used for screening of newborn babies. Hearing screening, it is used. For ideal gestation for screening of preterm baby is 34 weeker. And according to the Joint Committee on Infant Hearing 2019, the screening, identification, and intervention has been changed to first 1, 2, 3 rule. That is, in the first month you have to screen, second month you have to identify, and third month you have to intervene. And what are the risk factors? Risk factors include family history of hearing loss, NICU care of more than 5 days, neonatal hyperbilirubinemia requiring exchange transfusion, aminoglyc administration for more than 5 days, asphyxia or HIE, in utero infections, culture positive infections, craniofacial deformities, congenital microcephaly, syndromic babies, significant head trauma, chemotherapy, ECMO, and caregiver consent can also be included. So, thank you. I think our 15 questions got over.
Thank you, Princy. If like further questions, I think if we have time after Gokul's presentation, we can go ahead with that.
Yeah.
So next, that was wonderful for you to give you all these perspectives to PGs, especially all those routine normally asked questions. And I think you've covered all the areas in neonatology. Next, I'll ask Dr. Gokul. He's a consultant neonatologist at Aster MIMS, Kannur. And he's been kind enough to prepare some brilliant questions for you all. And I think he will not be able to ask out for PGs to answer. But if anyone knows the answers, please feel free to unmute yourself and then go ahead with the answers. And maybe a 15-second pause after the questions would be fair enough. Over to you, Gokul. Please, you can start with your presentations.
Yeah, thank you. Thank you, Doctor. So can you see the screen?
Dr. Gokul, we can't see. It's a blank screen that we're getting right now. It says you have started screens sharing, but I think you'll have to go on to your presentation as well. Yeah.
Okay.
Perfect.
Yeah. Now, can you see it?
Yes, we can see it now. Thank you.
Okay, thank you. So I have started the questions from 21st onwards because I thought there will be 20 questions from Dr. Princy, and this is the next question. So a term infant was 3 kilograms at birth, was admitted to NICU with lethargy and blood glucose level of 22 milligram per deciliter. So this is a case of hypoglycemia with symptoms. So what is the initial management?
Gokul, your slide is not moving. Now it's this.
Okay, sir. So what is the immediate management and what are the criteria for glucose monitoring, drugs that can be used for resistant hypoglycemia, and imaging of choice for pancreatic focal lesions? In some cases of hypoglycemia, we will have to get imaging of pancreas for focal lesion if the hypoglycemia is because of hyperinsulinism. So intravenous glucose therapy
2 ml per kg of 10% dextrose, followed by glucose infusion at 6 milligram per kilogram per minute is the treatment. So we have to follow the bolus dose with glucose infusion, because if we are not going with glucose infusion, that can lead to rebound hypoglycemia. So we should be doing glucose monitoring for those infants who are preterm, sick infants, if there is a large for gestation or small for gestation, and for infant of diabetic mothers. And the drugs that can be used for resistant hypoglycemia include hydrocortisone, diazoxide, and glucagon. And there can be others also which are in the trial. And 18F fluoroeldopapath is the imaging modality that can be used for identifying pancreatic focal lesions. So you can identify the instrument. This is the 22nd question. What are the indications for AEEG in NICU? Can you see the slide?
Yes, Gokul, we can see the slides.
Yeah. So what are the principles of AEEG? And 3 causes for decreased background activity in AEEG, and identify the EEG tracing abnormality. I'll show the EEG tracing abnormality in the next slide. So the indications for integrated EEG include therapeutic hypothermia, epilepticus, post-cardiac arrest. So any sick infant might need AEEG monitoring to identify seizures earlier. And in therapeutic hypothermia, it has got good prognostic value also. And the principles include filtration of less than 2 heads and more than 15 heads impulses, and rectification, as well as compressing the tracings. These are the major 3 principles behind amplitude integrated EEG. So if you get a slow background activity, it could be because of severe brain injury, or there can be scalp edema, which is causing decreased sensitivity of the electrodes. And if the electrodes are placed too close, and if the infant is on excessive sedation, these are the conditions when you can get
I think his network, he's got disconnected for some reason.
I don't may call Gokul.
Yes, sir. I'll just get on him. Princy, can we go ahead with the other questions?
Princy is having a few more this thing, you can continue, I think. Gokul has come.
Sir, there was some issue with the connectivity. That's right.
So technology also has its problems, but Gokul, please go ahead with the questions. I think.
Yeah. So I think my screen sharing is on.
Yes, Gokul, we can see your slides on the slideshow mode.
Amplitude integrated EEG that I have shown is a normal sleep wave cycle, because there is cycling and the initial continuity is maintained in the center. So I'll show you the normal AEG, normal as well as abnormal AEG graph, which can be used for identifying discontinuous normal voltage or burst suppression or severely abnormal like flat trace or very low voltage traces. So next question is regarding heart disease, cyanotic heart disease. This you have to enumerate 5 duct-dependent lesions. And next is initial dose range for prostaglandin E1 for patency of ductus arteriosus, and 3 long-term side effects of prostaglandin E1. The duct-dependent lesions can be of 2 types mainly: pulmonary duct-dependent pulmonary circulation as well as duct-dependent systemic circulation. So in duct-dependent pulmonary circulations include pulmonary atresia with impact intraventricular septum, tetralogy follows with pulmonary atresia, severe Epstein's anomaly, and critical pulmonary stenosis. And duct-dependent systemic circulation include coarctation of aorta, interrupted aortic arch, and HLHS. The initial dose for starting prostaglandin E1 ranges from 0.05 to 0.1 microgram per kg per minute. There is a dose range because in infants whom we know antenatally that the infant is having a cyanotic heart disease, then we can start prostaglandin earlier, and we can adjust the therapeutic dose once we have got the adequate response. If the ductus is closing and the
I think Dr. Gokul is having some technical issues. We'll wait for a minute or so. Gokul, we can't hear you.
can you hear me now? Hello?
Very soft.
Hello?
Yeah, it's better now.
Hello? Yeah. So the side effects include short-term side effects are apnea, seizures, hypotension, tachycardia, and hypoglycemia. And the long-term side effects include metabolic acidosis, metabolic alkalosis, hyperostosis, and gastric outlet obstruction. Next question is regarding the instrument pulse oximeter. So what is the principle of pulse oximetry? And what are the advantages of SET or signal extraction technology in pulse oximeter? And in usual normal pulse oximeters, what is the reliable range between what percentage of SpO2 to what percentage of SpO2? Like the range is between dash and dash percentage of SpO2. And what are the expected changes in SpO2 with carbon monoxide poisoning and methemoglobinemia? And what is failed pulse oximetry screening test? Yes, the principle of pulse oximetry is Beer-Lambert law. And the SET technology has got advantages that it can show saturation or SpO2 in low coefficient, and there are lesser motion artifact and noise artifact, and the reliable range of SpO2 for a pulse oximeter is 80% to 95%, and normal SpO2 even with hypoxemia is seen in carbon monoxide poisoning, and lower SpO2 is shown in methemoglobinemia. So this is the pulse oximeter screening test as per the recent AAP guideline. and it is after birth, if the infant is on not on supplemental oxygen, at that time, if the infant is more than 24 hours, or if the infant is getting discharged, then we have to check the pulse oximeter on right hand and one foot. So if the pulse oximetry reading is less than 90% in either of them, it is a failed pulse oximeter screening test. And if it is no, and if the pulse oximetry level or the SpO2 is more than 95% at both sides, and if there is a difference of more than 3% in between the both links, we have to do a retest. And if still it is the same, that is a failed test. And if otherwise, it's a pass pulse oximeter screening test. Next is regarding a drug, sildenafil. So what is the mechanism of action of sildenafil? The dose of sildenafil in PPHN? What are the side effects of sildenafil? What are the drug interactions to be concerned in NICU while using sildenafil? And name 4 other drugs that can be used for decreasing pulmonary hypertension. Yes, the mechanism of action of sildenafil is PDE5 inhibitor. It is PDE5 inhibitor, and there is a cGMP accumulation leading to vasodilatation. The dose range is 0.5 to 2 milligram per kg to 6 to 8 hourly orally, and intravenous loading of 0.42 milligram per kg over 3 hours, and a maintenance of 1.6 mg per kg per day. And the drug interaction that we have to be careful is regarding fluconazole, because it can decrease the metabolism of sildenafil and it can increase the concentration of sildenafil in the blood. And the other drugs include inhaled nitric oxide, bosentan, milrinone, PGE1, prostacyclin I2. And yeah, oxygen. So these are the major the mechanism of action of sildenafil and other drugs which are currently studied. And these are the other regarding the known drugs. And this is the mechanism of action of milrinone and PGA2 analogs. So next question is regarding a procedure, lumbar puncture. What are the 4 indications of give us 4 indications of lumbar puncture in NICU? What are the 3 indications for repeat CSF analysis? Contraindications for lumbar puncture. Yes, we do lumbar puncture to detect meningitis. So in case of culture positive early onset neonatal sepsis or suspected late onset neonatal sepsis, we have to do CSF study. Then primary HSV4 mother, post intraventricular hemorrhage with ventricular dilatation leading to hydrocephalus. Then inborn also metabolism for assessing the metabolite levels in the CSF. And we have to do a repeat CSF study in case of sepsis with MRSA or gram-negative, and if there is post intraventricular hemorrhage and ventricular dilatation with hydrocephalus, we might have to do serial lumbar punctures. Positive HSV PCR from CSF, again we will have to do a repeat lumbar puncture. Fungal meningitis, we will have to do repeat lumbar puncture to decide on the duration of antibiotics. The contraindications include unconducted bleeding abnormality, infection near the puncture site, raised intracranial tension, lumbosacral anomalies, and severe cardiorespiratory instability. I think you are all familiar with the instrument. So identify the instrument. What is the principle of the instrument? 3 advantages and 3 disadvantages. Yes, it is transcutaneous bilirubinometer. Optical spectroscopy is the principle, that is light is applied to the skin and the reflected light is measured. It is non-invasive, it gives fast results, and it can be used in the bedside, and it is cost effective if we compare with the cost of blood sampling and getting the result. But it is not accurate in the initial hours, sometimes in darker skin or meconium stained skin, and after 1 week and above 15 milligram per deciliter, and if the infant is has already received phototherapy. Question 28. A term infant who was born to non-consanguineous parents was admitted on day 5 of life with multiple episodes of seizures. There was no fever. The glucose level was 74 milligram per deciliter admission. The infant was feeding well at home and had no history of asphyxia during the delivery. Mother had history of loose stools 1 day prior to delivery. MRI was done as a part of evaluation, and it showed the below findings, and it was helpful for the diagnosis. So in this MRI, there is diffusion restriction, mainly in the subcortical white matter, then corpus callosum, and it is extensive diffusion restriction. So with the history, and as the infant had seizures on day 5, with the help of MRI, we can probably diagnose the condition. So we have to confirm the diagnosis and what is the prognosis of the condition, and state another cause for similar MRI findings. So the most probable cause is rotavirus associated leukoencephalopathy, and we can confirm it with stool PCR for rotavirus. Usually the CSF PCR is negative for rotavirus, and usually it has got a good prognosis, but the infants need neurodevelopmental follow-up. Earlier, there was an entity known as fifth day fit, and it may be because of rotavirus associated leukoencephalopathy. And the other viruses that can cause similar changes are parvovirus and enterovirus. Next is a question from statistics or research methodology. So give expansions of consort, probe, start, prisma, and more. From the expansion itself, we can identify for what it is being used. So first one is consort. It is consolidated standards of reporting trials. And second is strengthening of the reporting of observational studies in epidemiology. So it is mainly for the observational studies. Next is standards of reporting, diagnostic accuracy of studies, that is STAR. Then preferred reporting items for systematic reviews and meta-analysis, PRISMA. Meta-analysis of observational studies in epidemiology, that is MOOS. Next question is regarding antenatal steroids. And as per the Government of India guidelines, antenatal steroids are recommended from days to days weeks. Which steroid is recommended in India, and what is the dose? Yes, that is 24 weeks to 34 weeks. Correct, Dr. Sharandy. It is dexamethasone. And why the other commonly used steroid is not recommended in India? And next question is, what are the advantages of antenatal corticosteroids? And what is the recommendation of repeat dose of steroids as per the National Health Mission recommendation for India? That's a 4 dose, correct? So antenatal steroids, as per Government of India guidelines, are recommended from 24 weeks to 34 weeks. And it is intramuscular injection of dexamethasone 6 mg 12 hours apart, 4 doses. In India, the usual betamethasone acetate plus phosphate, which is the dose that can be given 2 doses 12 hours apart, is not available. That salt is not available in India. And betamethasone phosphate is available, but it is short acting, and the dosage is similar to dexamethasone. You will have to give 4 doses itself, and it is more costly, and there is no added advantage with the betamethasone phosphate. So it is not recommended, but you can give betamethasone phosphate if the facility is not having dexamethasone. Otherwise, you are not supposed to use betamethasone phosphate for as antenatal steroid. The advantages are reduction in respiratory distress syndrome, reduction in intraventricular hemorrhage, reduction in necrotizing enterocolitis, as well as reduction in mortality in preterm infants. And repeat dose of antenatal corticosteroid is not recommended as per Government of India guidelines. So this is another question from statistics. In a novel trial to reduce the incidence of NEC in less than 26-week infants, drug X was used, and the result is in the table. And you have to find out the relative risk, odds ratio, risk difference, number needed to benefit, and relative risk reduction. So with this time frame, it's a little bit difficult to get answer for it. And I have included this only for the only because this is a teaching purpose, and you might not be able to do it the whole answers within 2 or 3 minutes, unless you are well versed with formulae and mathematics. So relative risk is the risk of the first. Yeah, you can consider this as A, B, C, and D. Okay. So relative risk is risk for those treated with the drug and those who are not treated with the drug or were given placebo. That is A divided by A plus B divided by C divided by C plus D. So if it is less than 1, that means the relative risk or the treatment has got some benefit. We cannot tell it is a significant benefit or not. So it is 0.4 as per the question, and odds ratio is again the odds of having the outcome in the treated group, the ratio of odds of having the outcome in the treated group versus the untreated or placebo group. And the risk difference is the difference of the risk that you can achieve by the treatment, and number needed to benefit is here you can see that it is the risk difference is 0.1. So 1 divided by 0.1, it comes to number needed to benefit is 10. That means if you treat 10 infants with the drug, 1 case of NEC can be prevented. So relative risk reduction is 1 minus relative risk, that is 0.6. That is the risk, relative risk that is reduced with the drug. So next is regarding CPAP. What are the advantages of early CPAP in preterm infants? What is the criteria for early rescue surfactant therapy for preterm infants? What are the advantages and uses of HSF-NC, heated humidified high flow nasal cannula? So the early CPAP reduces the incidence of BPD, the combined outcome of death and BPD, and the need for mechanical ventilation. The criteria for early surfactant administration, early rescue therapy with surfactant is FA2 more than 30% with a PEEP of 6 centimeter of water or more. Mechanical ventilation required as a part of initial stabilization for preterm infants, and those infants less than 26 weeks with respiratory distress. And high flow nasal cannula has got advantages of lesser nasal injury, and it can be used for weaning from CPAP or mechanical ventilation, and it can be used for apnea of prematurity, respiratory distress due to bronchiolitis or pneumonia or BPD. But it is inferior to CPAP in being used as a primary modality for treating respiratory distress syndrome. So a primigravida mother delivered a term AGA infant vaginally, and the obstetrician noted genital lesions which are characteristics of HSV for the mother. And the mother had no history of HSV infection in the past. So what are the tests that you order for the mother? And what tests would you order for the infant as initial evaluation? And what is the time at which you will send this test? And what is the drug? Is the drug used for treating the condition and the dose? And how long are you going to treat for CNS infection? And how long will you treat the infant if the initial results are normal for the infant, but the mother has got first episode of primary infection and the mother has got some positive results? So for the mother, you'll have to send swab for HSV PCR, then serology for HSV1 and HSV2, as well as the culture. At 24 hours for the infant, we have to send surface cultures from conjunctiva, mouth, nasopharynx, and rectum. And the next test is HSV blood PCR, HSV CSF PCR along with the CSF study, and serum ALT. The drug that we give is acyclovir at 60 mg per kg per day, and the duration will depend upon the results for the infant. If there is CNS disease, we'll have to give 21 days or 7 days after the negative HSV PCR in CSF, whichever is long. And if all the tests are negative for the infant, but the mother is having primary HSV, then we'll have to treat the infant with acyclovir for 10 days. So I have tried to put all the AAP guidelines from 2013. If you want to take a picture, it might be useful because it is not the font is not that much big. So question number 34, identify the condition. What are the types of the condition, and what are the other conditions that are associated with this? What are the options for managing the condition? So in the X-ray, we can see the coiling, and the diagnosis is esophageal atresia. Can be type A with a blind ending esophagus without any fistula, or type B with the fistula with upper portion of the esophagus and a blind ending falls on the lower side, or it can be type C, which is the most commonest variety, or type D, or type E, which is otherwise type X. The associations include Brachial association, Charge syndrome, trisomy 21, etc. And the primary repair and ligation of the tracheoesophageal fistula, if present, is the initial mode of surgical repair, or it can be stage repair if there is if the length between the two pouches are very long. We will have to go for stage repair with lengthening of the esophagus by traction sutures, or we might have to use jejunum colon for replacing the esophagus, or we will have to do a gastric reposition. So this is regarding ventilator graphics. What is the diagnosis, and what correction step would you do in this condition? So here we can see that this is the inspiratory flow, and there is a close, and there is expiratory flow, and there is abrupt ending of the expiratory flow. So it is a wasted TA, and there is no the TA is wasted here because the whole TA is not being used. TA is higher, but PE is lesser. So there is air trapping in this. So you can see that in the loop is not going to the zero, and there is air trapping. So what is the corrective step? You will have to decrease the TI, increase the TE. So what is the diagnosis from this PV loop? And what correction step will you take? And what does the pointer denote? So here we can see that there is beaking of the PV loop. So there is overinflation, hyperinflation is happening. So we'll have to decrease the pit, and this pointer is denoting upper inflection point. Here is the lower inflection point, and this is the upper inflection point. So if there is extra time, I can put two more questions. So here, which is the mode of ventilation shown? And what are the advantages of the mode? What are the two contraindications for using this mode in infants? In this mode, we can see that there is squaring of the flow rate. Flow rate is squared. So this is a volume control ventilation or volume targeted ventilation. So with volume control mode or volume guarantee mode, we can have lesser volume trauma and lesser duration of mechanical ventilation in preterm babies, especially preterm babies, and lesser air leaks, stable carbon dioxide levels, which prevents PVL, and there is a decrease in DPD. And volume control modes are contraindicated with single length ventilation, and if there is excessive leak of more than 40%, because it might get compensated and it can again lead to volume trauma. This is an additional question. Identify the chart. The equipment used to measure irradiance, wavelengths used for maximal benefit in phototherapy, unit of measurement of irradiance, and dose of light delivered for intensive phototherapy. So it is a Bhutani mammogram, which predicts the risk for severe hyperbilirubinemia. The irradiance can be measured with Lux meter. The ideal wavelength is 430 to 490 nanometers, and the unit is microwatt per centimeter square per nanometer, and it is 30 lux, which is the intensity for intensive photoproduction. Thank you.
Thank you, Gokul, Dr. Gokul, for this wonderful presentation. I think it was very informative for the postgraduates as well. So, sir, should we, Dr. Princy,
any questions from the postgraduates you can invite if there are any?
Dr. Princy, Dr. Gokul, postgraduates,
Yes,
you can ask any questions regarding these particular questions as such.
Okay.
Prince, in the breast analyzer, are we doing sodium and other things on 14 only?
Actually, we are not using in our unit. There is no analyzer, sir.
Oh.
And for sir, your targeted fortification, no, sir. Individualized fortification you are talking about, no, sir. And in that, actually, proteins are analyzed, sir, with the help of milk analyzers. And we don't have a milk analyzer in our unit.
Okay. Extensively covered, I don't lay.
Yes. Another thing about what Dr. Gokul mentioned about the 5th day seizures is like earlier we used to label most of our benign seizures or one episode of seizures as 5th day benign. But if you're having recurrent, not so easy to control, I think it is better to send CSF PCR as well for especially diagnosing this and get an MRI as well. Because the LP will essentially be normal or like a viral picture in these cases.
Actually, the rotavirus, I had an experience a few years back with one of the doctor's kid, and that time I was not aware of this entity. Rotavirus is a reason for this MRI picture and all, and the child was followed up, and now he's almost 5 years old, so he's a normal child. There were some problems in the early development part. MRI was suggested, and the PCR proved rota.
And these risk babies are high-risk babies are essentially all those low preterms, late preterms, low birth weight ones, especially who are at risk. I don't know how many of our babies, if you do normal babies, if you do stool rota, how many of them will come positive?
And there were cases of Paraco also. We had
Paraco.
Okay. Gokul, I was interested about the amplitude, okay, the EEG, the different patterns. You moved a little faster. Maybe the question 24 or 23. EEG, different styles, different patterns of normal and other EEG. It's informative, but I don't know about that. Or 5 questions. The next slide. This one. You explain that.
Yes, sir. So here, actually, in the amplitude integrated EEG, it has got 3 principles. That it filters the slower frequencies as well as higher frequencies, because it may be because of the noise or the artifact. And next is it rectifies the impulses, and it compresses to 6 centimeters for 1 hour. So here in the normal EEG, the lower margin is more than 5 microwatt and upper margin is more than 10 microwatt. So you can see that it is above 5 microwatt and it is above 10 microwatt. So, and it will be compressed, and so the waves will be thickly, or we can see it in a more dark color. Okay, this is the normal one. So once this infant has got sleep-wake cycling, it will show a cycle. Like slowly it will cycle. And if it is abnormal means there can be the lower margin comes below 5. and the upper margin is still above 10. That is moderately abnormal, or that is known as the discontinuous voltage. Because if it is continuous voltage, it will be thickly shown, like a dark portion like here. So this is a discontinuous normal voltage. And if it is burst suppression, it is more abnormal. So it comes mainly the lower border comes directly at below 5, and from the burst comes. And in the severely abnormal form, it is actually less than 5 volt and less than 10 volt, or it is the low voltage form. And flat trace or the isoelectric is even worse.
Okay. In the burst suppression pattern, what do you mean by this thing? There are two patterns in the burst suppression pattern. That's it.
Yes, sir.
Okay. Okay, that's enough. Mohandas is there? That's Poyo.
Sir is there. Sir is there.
Okay, okay. Well, it was a very useful, informative session. We learned a lot. That's a parnolo.
Arun, you can conclude.
Thank you, everyone. Thank you to the presenters, especially for collating all these interesting questions and actually more useful during having practical applications as well as for examinations. So I think they're covering both. And thank you, Dr. Princy and Dr. Gokulas. It was a brilliant session. I think even we also learned a lot of things, like Dr. Purushothaman sir said. And I think he was the one who was more attentive than any one of us, asking questions in between as well. So thank you, Mohandas sir, for again organizing this program for postgraduates. And hopefully we'll see you at all of you all at the next session. And happy learning till then in between as well. And we'll be able to collate these questions later on for postgraduates to have for easy workup or learning before the exams, especially. Thank you, everyone, for I think good night, and we'll see you in the next session.
Good night. Okay. Bye.
It was a very nice session.